this is a 29-year-old gentleman who presents with a 1-week history of painful swelling of the finger. And from an undergraduate point of view, I want you guys just to learn to assess this sort of case, and then we'll talk about it at a postgraduate level as well. So from an undergraduate point of view, remember it's history, examination, special investigations. The history is this patient works with motor cars, but he denies any penetrating injury. He developed spontaneous onset of pain and swelling of the right ring finger, and for the last week or so he's been unable to make a fist, nighttime throbbing, and he eventually resorted to making a little incision to try and let what he knew was the pus to come out. So that's on the history. There are no comorbidities, that's important as well. Specifically his RVD status. When you start feeling, the important thing once again is not to feel generically. You need to try and feel what you're feeling for. And what you're feeling for here is to try and work out where the tenderness is. What we're trying to ascertain is whether the infection is localized to there where you can see the bead of pus come out, or whether it's actually gone deeper into the flexor sheath. So you want to feel proximally. Tell me, is this sore?
No.
Not sore, eh? Not sore there. So that's a very important sign. It's not that sore over here. It's sore on the back of the thing, but if I push on this side, it's not that sore, eh? Okay, on the back it's sore. So that's what you're feeling for. And then the other thing you're feeling for is to try and feel fluctuance, but you won't feel it. It's going to be too tender and it's not that full of pus. And you want to maybe test the temperature, but it's very difficult. Really what you're trying to work out is where it's sore. And then when it comes to move, you want to get the patient to move, make a fist. So it's very limited flexion, as you can see. Open extend, the fingers held in flexion. So what we're starting to see are the signs of Canavel, which are the signs of a flexor sheath infection or not. So the signs of Canavel are swelling along the whole course of the finger as opposed to just an area. The fingers held in a slightly flexed position. He's tender along the whole course of the flexor sheath, which in this particular case he isn't that tender proximally where you'd expect it to be, and there's no tenderness proximally here where the bursa might extend to. But he does have one positive sign, and that is when you passively extend the finger, he really doesn't like it. So that's a bit of a worry for a flexor sheath infection. If we turn him over, you'll see that there's generalized swelling, which you normally wouldn't see this with a flexor sheath infection. There's sore there, and it looks like some firm induration going down into the web space, and you get the feeling these fingers are starting to push apart here, implying that there might be a tracking down to the web space. So that's from an undergraduate point of view, this is a bare minimum. It's a bad hand infection, subcutaneous in the pulp area, maybe going down to the flexor sheath, and it needs to be referred for incision and drainage. There's no place for antibiotics in this case. I think that's the most critical thing you have to understand. You cannot treat this with antibiotics, it needs drainage. From a postgrad point of view, the only thing you have to decide now is whether it needs to be opened down to the flexor sheath or not. If you open the flexor sheath inadvertently in the face of pus, you risk introducing pus into the flexor sheath. But if you don't open it and there is pus in there, then you have a neglected flexor sheath infection. My gut feeling for this patient is no flexor sheath infection, because I just don't think this sign is positive enough, and I don't think that you should be way more tender over there. So I would just open this up as a normal incision and drainage and have a look at the flexor sheath. If it's showing signs of bulging, then I would have a low threshold for opening up proximally and distally and washing it out, flushing it out. But otherwise, try and avoid opening the flexor sheath. Obviously, pus swabs and then empirical antibody coverage.